Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy You, Healthy Nation, Healthy World. I'm Nancy Valentine, PhD and registered nurse, and this show is dedicated to you, the healthcare consumer. And today we have a renowned physician who's going to be talking with us about a topic that you probably haven't heard a lot about, and that is heart arrhythmia. As I said to our guest, who I'll introduce in a moment, Dr. Peter Cowie, most people, when they hear about heart arrhythmias, only when they have a diagnosis of heart arrhythmia, then they hear a lot about it. But the average person doesn't know very much about it. So the title of our show today is Rhythms of the Heart. What you don't know can hurt you. And so today we're going to talk about it so that you will know about it and you will be prepared. So let me take a moment to introduce our guest, Dr. Peter Cowie, who is a renowned person internationally as well as here in the Philadelphia area as a heart rhythm specialist, and he works in detection and treatment of heart rhythm disorders. So welcome, Dr. Cowie, and I'd just like to tell you all about him. Dr. Cowie is a professor of medicine and clinical pharmacology at Jefferson Medical College. He is also chief of the Division of Cardiovascular Diseases at Mainline Health, and he resides primarily at Lankenau. He also does cardiovascular research at the Lankenau Hospital and Medical Research Center, often referred to as LEMR, also at Lankenau. And Dr. Cowie is a graduate of St. Joseph's University and the University of Pennsylvania School of Medicine. He then went to Harvard University School of Public Health and spent time in the Boston area training there before coming back to the Philadelphia area. Dr. Cowie has written many, many books and journals. He has spoken all over the world. He has a CV, by the way, that I think he could bind and sell as another book in his collection because it's over 100 pages of all the things that he has done in over 30 years. But for all of his accomplishments, I think what is very likable about Dr. Cowie in terms of our topic today is that he can really talk to you in your language so that you will understand all about heart arrhythmia by the time we finish. So thank you, Dr. Cowie, again for being with us, and educate us about heart arrhythmia.
Well, first of all, thanks for the invitation. It's just wonderful to be here, and also to have the opportunity to talk about this topic, because I completely agree with your premise, which is that this is something that a lot of people don't know a whole lot about, but unfortunately affects really literally millions of Americans. The rhythm I think that we'll probably spend most of our time talking about is atrial fibrillation. That's just a rhythm that is, it's not a lethal rhythm. It doesn't cause people to die suddenly, but it's associated with a very, very significant complication, which is stroke. Mm-hmm. And I talk to my patients, Nancy, and they tell me over and over again that they would probably rather be dead than have a disabling stroke. In many respects, stroke is worse than dying, especially if it lands you in a nursing home or completely incapacitates you. So the reason why there's been a tremendous amount of interest in this particular arrhythmia, first of all, it's very common, and especially in the elderly population. And secondly, because we would really like to prevent these strokes from occurring. We estimate that over a third of the strokes that occur in the United States, then there's 700,000 strokes in the U.S. every year. A third of those are attributable to this arrhythmia.
Right. So it's atrial fibrillation. Sometimes you'll hear it referred to as AFib. That's sort of the short version. And tell us how you can sometimes get this, especially you refer to the elderly. Does this happen out of the blue, or are there other things that occur that then have this as a consequence?
So, great question. Atrial fibrillation is very complicated because it can occur in people who have no other heart disease. So at one end of the spectrum, it can be out of the blue, completely unexpected, and very obviously healthy people. And then at the other end of the spectrum, people who have advanced forms of heart disease like heart failure or valvular heart disease can also come down with this arrhythmia. But what we do know is that as one gets older, one is much more likely to develop it. So just to give you some idea, if you make it to the age of 40, you have about a 1 in 4 chance for the rest of your life of developing atrial fibrillation.
That's high.
It's an amazingly high prevalence in the population. And the thing that's happening, as you know, Nancy, is that our population is graying, it's getting older, people are living longer, and they're living with diseases like high blood pressure and diabetes that predispose to this arrhythmia, and they're not dying from those diseases because they're getting great care for those diseases, but yet they go on to develop this arrhythmia, which is a complication. So we're seeing a lot more of it, and we're obviously very much worried about it.
That is very interesting. I don't think most people think that that's associated with high blood pressure or diabetes. But I think it's really good to have that understanding that if you're being treated for either of those disorders, it's so important to follow the regime, the medication, the exercise, because you could have that under control and that not only be tackling that illness, but something like this that could be sort of downstream as a consequence.
I think that's very well put. We have pretty good evidence that controlling hypertension, high blood pressure, and controlling diabetes and controlling other forms of heart disease does reduce the chances of developing this arrhythmia, and not controlling it, on the other hand, does complicate the matter.
I think it would be really helpful if you could explain to us when you start talking about a problem with the beating of the heart, then how does that wind up with a stroke?
So atrial fibrillation is an arrhythmia that affects the upper heart chambers. And as you recall from old high school physiology, the top chambers of the heart are the primers for the bottom chambers. So the top chambers contract, pump blood into the lower chambers so you can maximally squeeze as much blood as you possibly can into the circulation. It turns out you don't absolutely have to have those top pumps working. And so if one of them goes out, and that's what atrial fibrillation is, it's an inability for the top chambers to function normally, and they're not moving and contracting, the blood creates coagulation within the upper chamber. The blood becomes static and kind of swirls around, and clots form. When blood isn't flowing, it clots. And those clots that form in the upper chamber can leave the heart, and when they do, they frequently go to the brain, and that's what causes a stroke.
Now, in terms of symptoms, if someone was walking around that 1 in 4 over 40 and they didn't have heart disease or they didn't have diabetes, how would they know that they might have this?
Well, that's really the crux of the problem, is that it's sometimes not that easy to detect. So the most common way of presentation is the person feels the heart beating irregularly and rapidly, and reports that to their physician, and the physician does an electrocardiogram or some kind of a recording that shows that atrial fibrillation. Unfortunately, in many patients, the symptoms are much more subtle. So they may feel overly tired, or they may be a little bit more short of breath going up a flight of stairs, or they just aren't sleeping right, or they're not eating right. They're not functioning, they're not exercising, they're not able to do what they want to do. And then occasionally those patients are detected. But the most startling thing is that about 20 to 25% of patients who are diagnosed with this arrhythmia are diagnosed completely incidentally. They go to the doctor's office, the doctor does a cardiogram or takes their blood pressure, takes their pulse, and says, "Oh my goodness, your heart's out of rhythm," and that's how they discover it. The reason why that's very important is because even though they don't feel it, they still are susceptible to having the stroke that we talked about. So we're actually in the middle of a very large project trying to determine in freestanding elderly populations how many people out there actually have this and don't realize it.
Walking atrial fibrillation cases.
Yeah, exactly. Yes.
But in that case, say that it is detected. Maybe you go to your annual physical, or you do have those symptoms, which hopefully you follow up with immediately. You know, you don't let them just sort of like, I'm not feeling so good, and like suddenly it's 6 months and you're still not feeling that well. You should really have that checked out. But say you do that and you have it checked out. What is the usual treatment?
Well, the good news is that there's been a tremendous amount of interest in this arrhythmia on the scientific side. And so the good news is that if you are diagnosed to have atrial fibrillation, we have lots of things that we can do to help you and treat you to make you feel better and live better, and also prevent strokes. So there's a wide variety of ideas. And the other piece of good news is that there are now specialists in the area of cardiology who take care of these rhythm abnormalities, who are very well versed and really know how to take care of these problems. So the good news is that we've concentrated a lot of effort on this.
But give us an example of a case of what would happen to that person. Okay, they get the basic cursory diagnosis. It's not that hard to diagnose.
No, it's a pretty simple diagnosis.
Right, so, okay, so you get it and you go, okay, now what? What happens?
So the very first thing that would happen is that you'd go through an evaluation to make sure that you didn't have any form of heart disease that would be causing the atrial fibrillation. So ultrasounds and maybe a stress test and some blood tests, pretty simple things. Once all that was established, and then the treatment of the arrhythmia would be usually medication, medications to control the abnormal heart beating and the rate of the heart, and then blood thinners, if appropriate. Not everybody needs them, but the majority of people do. And when they do, we now have a number of options to thin the blood to prevent a stroke, while at the same time not causing other problems.
Right, so the treatment, from what you're telling us, is really not to reverse the atrial fibrillation, but just to control the symptom enough so that you don't have any bad consequences of it.
Well, there are actually treatments that we do have that will actually reverse the arrhythmia.
Okay, tell us about that.
Some of them are medications, as I've already mentioned, but we also now have available techniques where you can put catheters inside the heart and actually destroy the abnormal circuits within the heart. It's called an ablation procedure. They're done fairly commonly. They're not the world's easiest procedures, and obviously, once putting catheters inside somebody's heart carries some risk. So we don't do it in every patient, and we don't do it until they've had some other form of treatment. But it's another option for treatment. So there's lots of things that can be done. The really important thing to remember, Nancy, here is that each patient is different, so that each patient requires a little bit of a different approach, a different therapeutic approach. It's a pretty challenging arrhythmia from the doctor's side, but the good news is from the patient side is if you get to the right doctor and they do the right stuff, that you should be able to do fine with it.
Right, so the whole goal here is stabilization. Maybe reversal in some cases. Is that age-related? I mean, even though every patient's different, are there some trends like what you would do
absolutely,
with certain people at certain ages and stages?
Yes, absolutely. And for example, in a very elderly individual, I don't think we'd be spending a lot of time thinking about catheters in their heart. I think in those patients, we try to use medications that are gentle enough so that they can tolerate them. Still want to prevent those strokes, because even in the elderly, functional elderly people do very, very well, as you know. But if they have a stroke, especially in the elderly, that's very likely to become disabling, and their life is pretty much over. So there's lots of very difficult decisions to be made in individual patients about these things.
Interesting. Do they know what causes this?
So the fundamental problem that causes this, the final common pathway is, as you get older and with these diseases that we've been talking about, the normal atrial tissue, the muscle in the atrium that contracts, gets replaced with scar tissue, fibrosis it's called. And as this fibrosis invades into the tissue of the atrium, it sets up these abnormal electrical circuits that cause these abnormal heart rhythms. What's interesting is that there appears to be a genetic predisposition. So if it's something that's occurred in your family, you're much more likely to get it as you get older. Not that you're certainly going to get it, but you're much more likely to get it. And then there are some diseases that cause this fibrotic picture like hypertension and diabetes that we mentioned, that increase the probability of developing it. So we're getting a little bit smarter in understanding the physiology of what's happening, but unfortunately we're still not all the way there.
Right, right. Well, it sounds like for many people they can live with it. I mean, with that number of people, 1 in 4 after 40 really being predisposed to this or very likely to get it, that's a very high statistic. But it sounds like with the treatment, they can live a very normal and long life.
Yes, I would say that I see hundreds of patients a month in our offices with this arrhythmia. And I would say that we achieve a goal of functionality in everybody. It's a very, very rare patient that doesn't come out of this whole treatment paradigm feeling like they can do what they want to do, at least to be able to accomplish their daily activities, to exercise, to lead as normal a life as possible. Now, unfortunately, it may not be perfect. I mean, there may still be some times when they have symptoms, But we are able to get that down to a point where they don't have to go to the emergency room, they don't have to have frequent doctor visits, and they can still function and do the things that they want to do.
That's great. I mean, I think that's the whole goal of treatment. The whole goal of treatment is to really restabilize so that you can do all those things that were the symptoms that brought you to the doctor to begin with.
And I want to emphasize something you said earlier because it's so important. You said something about exercise, and exercise, it turns out that there are very few things that we can do in medicine that is as good as exercise for anything. It's so simple.
One size cure all.
It cures everything. I've never seen a disease state where heart failure or valvular heart disease or anything where exercise wasn't helpful. And there are now data to say that if you have this arrhythmia and you have a regular exercise program, you will do better. You will have fewer strokes, you will have fewer hospitalizations, you'll be more functional. Because what exercise does is it makes your body able to get by with less blood flow. It makes your muscles much more efficient, and it's just a wonderful thing to continue. So I really encourage patients not to stop exercising. I mean, obviously, when you're in the middle of an illness, you can't exercise, but when in the daily activities, exercise should be at the top of the list.
Well, one of the goals of our show is that we talk a lot about healthcare reform, but one of the bottom line messages is that healthcare reform starts with you. And as you reform your regime, your daily life, I think what Dr. Cowie said is one of the best kept secrets in medicine. And I'm not sure that doctors even emphasize that enough.
I think you're absolutely right about that. And I'm disappointed. Obviously, I see a lot of patients as second and third opinion consultations, very resistant cases. And I'm amazed that, well, it makes my job a lot easier. I look like a genius because I do the simple stuff. And I go back and, well, have you been exercising? Well, my doctor told me I really should cut that out because I have this. Well, see, that's exactly what you shouldn't do. And when I get them back on treadmills or swimming or whatever, they start feeling better and they come back and tell me, you're really a good doctor. I feel a whole lot better. But it was such a simple, basic intervention. Another thing that people say is, well, you know, if you have this arrhythmia, you shouldn't have any alcohol and no caffeine. And that's nonsense. There's no evidence that the vast majority of people with atrial fibrillation have to give it up completely. You can't abuse it, but you can have a glass of wine at dinner or a cup of coffee in the morning. It restores an amazing quality of life. Think about it. If my wife and I don't have a cup of coffee in the morning, we would probably have been divorced a long time ago. And for people to give that up completely is very, very difficult. It's not necessary. And it immediately improves their quality of life when they get it back.
I think it's a very good point because we put so much emphasis on medication and medical research, and I mean, all these things are vitally important. But something is fundamental that is within the control of each person. Exercise, good nutrition, you know, a balanced life. It's very difficult to achieve for most people, but that should be the goal.
There's actually a paper that came out, Nancy, a couple of weeks ago in one of our cardiology journals about yoga in atrial fibrillation. And guess what? People who did yoga did much better than people in a control group. Why? For all the reasons you just said. It's a balance, it's relaxation, it's meditation, it's a quieting of all the bad stuff that happens in your brain. And it's physiologic because increased amounts of adrenaline fuel atrial fibrillation. So whatever you can do to bring those levels down, exercise, relaxation techniques, yoga, should absolutely help, and they do.
So as you're being kind to yourself, you're also being kind to your heart, and you're giving your heart a chance to repair and take advantage of whether the medication is kicking in or whatever, but you're really putting that whole package together.
Yes, and I think you're absolutely correct to emphasize that medicines are good, but there's a very famous quote from William Osler, one of the most famous doctor of all time, who said he's the best physician and knows the worthlessness of the most medicines. Appreciating even back in the 1800s, they didn't have as many medicines back then, that medicines are a double-edged sword. So we rely on them, they're very helpful, but if you can do things for yourself and improve your own condition, and you can, it certainly gives you a big step up.
You know, one of the things that you'll hear a lot in healthcare reform is this term called patient engagement. And what that really translates is how to have you, as the consumer, more involved in your care and taking more responsibility for your health. How would you think doctors and the team of healthcare professionals that are dealing with people today are going to incorporate that into their practice? Do you think this is you're going to see more of this become part of medical practice?
Yes, absolutely. First of all, our patients are much better informed than ever. I've been very impressed that well, when we now let's be honest. You and I have had our experience with patients on the main line for a long time, and this is obviously a very gifted group of people. But even within some of the other communities in Philadelphia, I've been very impressed with what people have learned about things, and one of the things that I think is very important for people to do is to ask lots of questions. It's really okay to ask your doctor questions and expect them to give you the answers. I also think it's important for your family to be engaged. I always enjoy seeing patients with their spouses and with their families because it becomes a much better communication. It becomes a much better dialogue, and you have other people involved. So asking questions and being involved, asking the right questions, obviously, as many questions as you can get answered, I think is very important.
Very good. I think it's really good to hear Dr. Cowie speak on his own behalf, but on the behalf of his colleagues, that physicians who, obviously are very busy or may not be asking you, directly, do you have questions, they're really inviting you to come with your questions so that you're really prepared for your visit. And I think that's really, again, refreshing to hear. Now, in terms of the research, you're on so many various research committees and you've been a consultant to many organizations. What's on the horizon for all of this? Where do you think the field is going?
Well, we're very, very anxious to work in the field and on the prevention side of these things. I think the best way to treat a disease, Nancy, as you well know, is not to get it in the first place. So we're working on a number of projects trying to understand, as we said a little bit earlier, how we can treat the underlying diseases better so that people don't get this arrhythmia in the first place. And then another initiative is prompt diagnosis and intervention so that people don't languish with this for a long period of time before they actually get treated. Then once they have the disease, the stroke prevention issue has been amazingly important. And as you know, and I'm sure the viewing audience knows, there have been a number of new blood thinners, for example, that have been approved over the last couple of years in the United States. It's created a good deal of controversy because of some of the data that have been published about bleeding and things, but the net is that these are really a remarkable improvement over what we've had available, Coumadin, for example, for years.
Can you say why they're an improvement?
They're an improvement because they're safer and they're more effective. We've because of the media nonsense about the bleeding issue, I think we lost sight of the most fundamental thing that we learned from the clinical trials of these drugs is that they work better than Coumadin and they cause less bleeding than Coumadin. All blood thinners cause some bleeding, unfortunately, but these are marked improvements over what we had available. And also, the thing that patients really like is they don't need to have all those blood tests that they used to have with Coumadin.
Right.
And then they don't have to worry so much about what they eat because, as you recall, Coumadin has a number of food and drug interactions. So they're simpler drugs in those respects and also more effective.
Wonderful. So for people that are on Coumadin, are they encouraged to talk with their physician about the new standards of care?
Yes. It doesn't mean that they have to switch. I mean, we have a lot of patients who remain on Coumadin. It's a good drug. Once it's been a good drug for you, a lot of patients really want to stay on it, and that's perfectly fine. But I think you have to have this conversation.
Right.
What might be best for me in this situation, doctor, and why? And what we do with our patients, after we have those initial conversations, we encourage them to think about it, do their own little research, and eventually some of those patients switch, but some patients don't.
So in addition to better drugs, what do you see happening in the field above and beyond drugs? Because you've really cracked the nut on some of these drugs.
Yes. We're very hopeful that these catheter techniques will become better, safer, more effective, easier to implement. Because the opportunity with these catheters and what we're hoping over the long term is that we'll finally be able to really get rid of this arrhythmia, completely get rid of this arrhythmia for some patients, at least some of our patients. Right now, we can occasionally get there, but it's still not really completely as effective and safe as we'd like. So the good news is that there are a large number of people who are really spending a lot of time trying to understand this. I speak at a meeting in Boston, for example, in January every year. There are 3,000 or 4,000 people from around the world come and only talk about this one arrhythmia for 3 days. And
wow.
Very intensive, very high level stuff. So people are really working very hard on this.
Right, because it sounds like the goal is really, if you look at the bigger picture, The goal is improve quality of life because you won't have this problem to begin with, or if you have it, it'll be managed very well. And the second and most critical is the stroke prevention.
Yes, exactly. And really, when you boil it all down, there's only two things that healthcare professionals can do for patients. They can make you feel better or live longer. And so, yes, our goal is to improve the quality of life of our patients, and I think we're doing pretty well in that regard, and then prevent the mortality, and most of the mortality of atrial fibrillation is stroke-related. Again, you know, the idea that someone can have a stroke really, I think, it really permeates our thinking in this arrhythmia. It's the very first thing I think about when I see a new atrial fibrillation patient is, what are we going to do about this risk? What can we do to optimize the chances of preventing a stroke?
So say in the ideal world, you were really able to manage all of these people. How many strokes would be prevented approximately in the United States?
If we could get rid of all of the AF strokes, we'd be preventing maybe 250 to 300,000 strokes a year.
A year. That's a lot of disability.
It's a lot of disability. And the other tragic thing about the strokes in atrial fibrillation is that they're big strokes. They're not little tiny strokes. They're not little mini strokes. They're actually very severe strokes. And the reason is because these clots that leave the heart are pretty big compared to the size of the vessels in your brain. So once they get up there and they lodge in a vessel, they can create a lot of damage.
Mm-hmm. Right. So these people, I mean, nobody wants to get a stroke under any circumstances. You could either be living a very disabled life, or you could die.
Yeah, that's right. A large number of these strokes are mortal strokes, and what we've learned is that the blood thinners not just reduce strokes, but they also improve mortality. So they reduce the chances of dying from the strokes as well. So it's a pretty interesting time. We're also working, by the way, Nancy, on techniques to try to put baffles within the heart to prevent the strokes from leaving the heart. So
that's interesting.
There's even device therapy for prevention of stroke in atrial fibrillation that's ongoing around the world. So there's, as I said, there's a number of companies, a number of people working on this very hard.
Thank you. Well, listen, in summary, just give us your prescription as to what people should do.
Well, I think the most important thing is to take really good care of yourself. Weight control, not really overeating and becoming indulgent, and exercise. I just can't emphasize how important they are in everybody's life. And I'm not saying it's easy. I have the same struggles everybody does, trying to keep my weight down and find time during the day to exercise. But it really does pay dividends. It really does extend life and quality of life. So that's the most important thing. If you're unfortunate enough to have one of these things happen to you, one of these heart rhythm problems, see a cardiologist and use that cardiologist to get you to the right people to manage it, because the biggest tragedy here is that people who have these problems and don't get to the right treatment. If you can get to the right people, the right physicians,
I think that's very critical.
It's really, really important.
So you have to have that conversation, maybe with your primary care doctor. You want to see a cardiologist, but then there's even a subfield of people that deal with arrhythmias. So it's really even a subfield of cardiology, and you really do have to ask those questions to be sure that you are seeing the appropriate treatment team.
Hit it right on the head.
Very good. Well, thank you, Dr. Coe. I've certainly learned a lot about AFib, and I hope that you will take some of these things away and use them for your own health assessment, and perhaps you know someone that could really benefit from this knowledge, and you will share it with them as well. Thank you very much for being with us today. Have a wonderful day. Bye-bye. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.